So, and you need to know your orientation. So in anatomical position, this would be the radial side, the ulnar side, lateral or medial. When they pronate, they keep that designation. So this is still the lateral aspect, medial aspect. So we're always going from anatomical. So in the wrist, you should be able to find the lunate. So to find the lunate, you find the third metacarpal, go down, slide over the capitate, which is S-shaped, bump and then a dip. And then it shares that dip with the tip of the lunate. So the tip of the lunate is at this end, proximal end of the dip here. You can feel the tip. You should be able to take it and capture it between 4 digits and just wiggle it up and down. It's convex on concave, so when I flex or rotate forward, it glides back. When I extend or rotate back, it glides forward. Okay, so you should be able to motion palpate the lunate, as well as just find the other bones, right? So especially the proximal bones, the pisiform on top of the triquetrum, the lunates in the middle, and the scaphoids out here. Clinically, the one we're worried about the most is what? Scaphoid, okay, because it breaks and it's problematic when it breaks. So you should be able to find their anatomical snuff box. Go like this for me, please. And find the snuff box, should be able to identify that the scaphoid is in the base of the snuff box, and that we have thumb extensors and abductor that define the snuff box. So we have the extensor pollicis longus, this one that goes about 45 degrees over the back of the wrist. Extensor pollicis brevis and abductor pollicis longus run over the radial stylite process.
That's the lateral side?
This is the lateral side, okay? So this is, and what they can get irritated here over the stylite process, what's that called? The tendon gets irritated and the sheath swells onto the tendon, called de Quervain stenosis tendinosynovitis, and that's, you're already ready to do the test for me, thank you, and we could do Finkelstein's test for that. Okay, but that's pretty unusual. My main concern here is the scaphoid, and so you should be able to find the snuff box and the stuff that defines it. Okay, what else for palpation here? Well, you know, the stylite processes, possibly of the ulna and the radius, and pisiform, triquetrum. Maybe, you know, if you get maybe the tendon of the flexor carpi ulnaris, since the pisiform is in it. You know, the chiropractor should know about that. The flexor carpi ulnaris tendon contains the pisiform. So, you know, it's a chiropractic problem. Some people get irritated pisiforms. Do a lot of upper cervical adjustment. Okay, what else? I think that's it palpation-wise. ROM, we know flexion is always greater than extension because the flexors are stronger than the extensors. And then on most people, ulnar deviation is significantly more than radial deviation. Okay, and then we got the orthopedic tests. So we have Phelan's and reverse Phelan's for carpal tunnel syndrome. So Phelan's, like this please, and you have to hold that for 30 to 60 seconds. So let's say 30, let's say 15, no, 30 to 60. And we ask them, does that make anything happen in your hand? Okay. What would a positive be? Numbness, tingling, altered sensation in the median nerve distribution. Thank you. We could also do the reverse Phelan's. The reverend might do the reverse Phelan's like this, and hold it for 30 to 60 seconds. Look for the same thing. Numbness, pain, tingling, typically in the median nerve distribution. Just wrist pain, some people consider that a positive test, but it's not really. It's not for carpal tunnel syndrome, because carpal tunnel syndrome involves median nerve entrapment. What else can we do for carpal tunnel? We could go in here and mash, see if we can reproduce the symptoms that way, or we might tap and see if we can reproduce the symptoms that way. Okay.
Wait, what is the tap?
Tittles. Tapping is tittles. And then we have a couple other tests here. We got Coases Mills, that's for the elbow. But Froment's and pinch test. So, yeah, I don't have my money. No, let's do this. Let's use this one. I can have you hold this like this. Okay. And they always show it like this. The true grip is really this way. It's a key grip. You use it all the time. How often do you do that? Hardly ever. Okay. But you do this all the time, right? You guys still have keys for things? It's not
No.
electronic.
Push to
Okay,
start.
so hold it, and you try to pull it away, and you look for this. Flex your hip for me, please. That is a positive Frommans, flexion of the hip. Why would they flex the hip? Because the hip is not powered by the ulnar nerve. We're testing ulnar. It's powered by the median nerve, anterior interosseous branch. So if you have a nerve lesion, you don't stop doing stuff. You just use what you got. And in this case, it would be the median nerve. Okay, because you're flexing the hip joint instead of keeping it flat, using more of an ulnar flexion. And then how do we test the median nerve? Flex the hip, as well as the dip and pip on the second digit. So if you go like this, just ask them to do that. If they have a median nerve lesion, anterior interosseous branch of the median nerve, typically they won't be able to do this. However, they will do that. Why can they do that? Because that's more ulnar, okay? So that's more ulnar, that's more median. So pinch test. And then what else we got there on the wrist?
Handshake.
Handshake. Really important. So I'm just gonna take your hand like this. It's like a handshake, except we're gonna ulnar deviate, and again, think about opening up, pulling on the scaphoid. So I'm gonna pull like this, the ligaments attached to the scaphoid are gonna pull it apart. If it's fractured, and it might hurt. If it hurts, I gotta point to the spot that hurts. So if the patient points over the scaphoid, then we gotta be thinking scaphoid fracture, and not something you wanna mess around with. Okay, so I'd refer out at that point, depending upon the patient, insurance situation and all that. Otherwise, go right to the x-ray. And if the x-ray is negative, I would still be skeptical, depending upon the time frame. Sometimes if it's new, the fracture line's not gonna show. So you might have to wait a couple days. Let those osteoclasts clean up the fracture line, and then you might get a better x-ray. Okay, is that it for the hand? Am I leaving something out?
There's a few more that we talked about in class, but they're not on here.
Like what?
Like trigger finger, Bunnell, Littler, wrist.
Oh, okay, Bunnell, Littler, I'm not going to test that. And those are pathologies. Okay, trigger finger. But so let's go to the elbow. Okay, elbow. So we got big bumpy things here, 3 of them. The medial epicondyle, lateral epicondyle, and olecranon process. Should be able to find those. On the lateral side also, we've got the head of the radius just distal to the lateral epicondyle. We also have ridges that go from the diaphysis out to the condyles, epicondyles rather. So you should be able to find those. I did ask you to memorize these guys, the wrist flexor pronator group. So if you go like this with your hand on your own arm, your thumb is your pronator teres, and then we have 3 flexors of the wrist. One is on the radial side, flexor carpi radialis. One's on the ulnar side, flexor carpi ulnaris, contains the piezoform. And then the one in the middle, if you have it, is called the palmaris longus. It doesn't attach to a bone, it actually attaches to the fascia of the wrist. So you should be able to name those. The pronator teres is especially important. It runs about like this because it can clamp down on the median nerve sometimes, give you pseudo carpal tunnel syndrome. And then on the lateral side, we have the wrist extensor supinator group. So you should be able to say something like extensor carpi, and then fill in the blank. Ulnaris, there's only one on the ulnar side, and on the radial side, we have a long and a short. All right? So we have the wrist extensor supinator group, and then we have the wrist flexor pronator group. What am I leaving out? Olecranon fossa, that's fair game. So if I flex the hammer belt like this and have it relaxed, I can stick my finger up and through the triceps tendon into the olecranon fossa. Should be able to find the biceps tendon, the brachial artery, that kind of stuff. Yeah.
It says on here ulnar border. It's not on this arm.
Ulnar border. Where'd you get that list?
This is from Smooth.
From where?
Smooth. Smooth now? Clinic entrance?
Oh, okay. Ulnar border.
It's not on the, it's not on the entrance, or it's not on
Oh, right, okay.
Can we go over the
I don't know what the ulnar border is. The ulnar border of something? Okay.
Ulnar border is
The ulnar border, okay. The carrying angle, okay, so postural exam, carrying angle is this. You're asking me to go like that. You know, why me? Why did I get the elbow? Because you were lucky, dude. The elbow is easy. No, how much is it? Typically 10 to 15 degrees. Some people say 5 to 15. Rarely you see somebody without one or a reversed carrying angle. That's usually due to if it's on one side, it's due to a growth plate fracture when they were a kid.
Radial artery is lateral.
The artery is medial to the biceps tendon.
Any other arteries with the carrying angle?
Valgus, absolutely, yes. Valgus, and you absolutely need to know valgus and varus, and valgus again. Describing a joint, the part distal to the joint moves away from the midline, that's valgus. Okay, if the part distal to the joint moves towards the midline, that is varus. So always to look at the part distal to the joint, or the bone itself. If you're describing a bone like the calcaneus, look at the bone itself. Okay, what else we got here in terms of orthopedic testing? Cousins and Mills occur here. And so Cousins test, let's have you stand up, please. So they're both for lateral epicondylitis, face me. I'm going to just go like this. Let's do the same, like this. So we're testing for lateral epicondylitis. So we're shortening the muscles on the lateral side, the extensors. And then I'm going to pull. Don't let me move it. Hold it. Hold it. Hold it. Hold it. Does that hurt? Okay, that is Cousins test. Okay, so could you do it with the arm extended? Sometimes you show arm extended. I don't think it really matters. Typically when you do a muscle test, you want to shorten the muscle. This shortens it over both ends. So don't let me move it, hold it. Cousins test, also known as the tennis elbow test. If it does hurt, you should always ask the patient, where does it hurt? Don't assume. I'm assuming, right? Because the book says it's going to hurt here. But don't assume, ask them where it hurts. So if it hurts here over the lateral epicondyle, that's a positive test. That's Cousins. So how else can we pull on that tendon, pull it away from the epicondyle? We could do a stretch test. So I'm going to have you go like this for me, please. Okay, and actually, let's have you flex your fingers too. It'd be better with fingers flexed. Does that hurt?
Yes.
Okay, where does it hurt? Okay, so the Mills test, this is Mills test, provoke pain at the distal over the area of the triquetrum, okay, on the dorsal surface. Is that a positive? No, because I'm trying to make it hurt over the lateral epicondyle. Okay, but you'd still report your finding, but it's not a positive Mills test, right? Because a positive Mills would be lateral epicondylitis. Okay, what about the medial epicondylitis? This stuff hurts. And again, what did I forget to do? Poke on there. Okay, go there and poke. Does that hurt? Does that hurt? Does that hurt? It's called digital palpation. It's an important exam procedure the chiropractors use. Okay, medial epicondylitis. Okay, how could I test that? The muscle test would be this. Go like this for me, please. Don't let me move it. I'm going to pull, hold, hold, hold. Is that okay? Okay, that would be the muscle test. And then to do the stretch test, I'm going to bring your hand. I'm going to bring it in the wrist into extension first. Then I'm going to extend the elbow. Is that okay in your wrist? Okay, and then I'm going to really crank into external rotation to try to check for medial epicondylitis. Thank you. Okay, and I think that's it for the elbow. No, valgus varus stress, I'm sorry. Valgus varus stress, just like the knee, I unlock because of the olecranon is in the olecranon fossa that gives added stability. So to test the ligament, I unlock a little bit, then I'm going to put a varus load on, is that okay? And then I can put a valgus load on. And ideally I should be standing there to do this load. Everybody with me? Valgus and varus stress, yeah.
What was the difference between the one you just did to check the medial epicondyle and then varus valgus?
No, this was varus valgus testing. I wasn't checking the condyle. Okay, I just said you unlock it first and then put a valgus load on and then a varus load. You ask if it hurts.
The one that you just did, like two before that looked like the same exact
Oh,
thing.
this one?
Cozen versus Mills. What's the difference?
The re-
Cousins